Hello, ma'am, can you hear me? Hello, ma'am, you are on mute. Please unmute yourself. Ma'am, please unmute yourself. You are on mute. Yes, now you are unmute. Can you speak something?
Sir, I'm Dr. Vaidyanathan, Secretary.
Yes, ma'am, your voice is audible now.
Sir, he's in round, sir. He'll join you within 20 minutes.
Sorry, ma'am.
He's in rounds now.
Ma'am,
Hello.
yes, ma'am.
Sir is in rounds now. He'll join with you 20 minutes, within 20 minutes.
Sure, ma'am, sure.
Okay, sir.
Good evening, sir. Can you hear me?
Yeah, Chetan, I can able to hear you. Chetan, sir, good evening, sir.
Yeah, good evening. This is Dr. Nambirajan.
Balaji, sir.
Balaji, audio clear இருக்குல்ல?
Yes, sir, clear இருக்கு, sir.
Video okay இல்ல?
Yes, sir, both audio and video clear, sir.
Thank you.
Chetan, make Kulashekaran also.
Sir வந்துட்டாரா?
Sir, வந்துட்டார். Sir, good evening, sir.
Good evening, sir. அவரது மியூட் ஆயிருக்கு.
Good evening.
Sir, good evening, sir.
Good evening, sir.
Good evening. Good evening.
Sir, how are you, sir?
Am I audible?
எஸ் சார். நம்ம திரும்ப மியூட் பண்ணிட்டீங்க.
Okay.
Sir, how are you, sir? This is Nambirajan.
Fine, sir. Nice meeting you, sir. Long time not seen.
Yes, sir. Yes, sir. We are not able to physically meet in the CSI meeting, sir.
Yeah, that is right. What happened to Shiva? Shiva has not come. எப்படி சார் இருக்கு கோவிட் கேஸ் எல்லாம்?
நிறைய இருக்கு சார். ரொம்ப அதிகமாயிருச்சு. எல்லாம் ஃபேமிலியா தான் அஃபெக்ட் ஆகுறாங்க. ஒன்றும் ப்ரெடிக்டே பண்ண முடியல சார். வேக்சின் போட்டவங்களுக்கும் வருது.
Sir, good evening, sir. Kulashekaran, sir. Sir, Sivabalan, sir, Kannan, sir, shortly they are going to connect, sir.
சித்ரா இங்க ஒண்ணு வாங்க சித்ரா. இதுதானே அப்படி மேல பண்ணணும். ஓகே. என்னது அது
சேர்ல போட்டிருக்காங்க டெஸ்க் போட்டஸ் கேமிக்கல போட்டிருக்காங்க
என்ன போட்டிருக்கலாம்
Hello.
Kannan sir, good evening, sir.
Sir, am I audible?
Yes, sir. Yes, sir. Your voice is audible, sir.
Okay, sir. I am also visible.
Yes, sir. Yes, sir.
Okay, sir.
லைட் இல்லையா கண்ணன் சாருங்க கொஞ்சம்
ஹலோ சார் பாலாஜி சார் சிவபாலன் சாரோட வீடியோ ஆன் ஆகல சார் கொஞ்சம் வச்சுக்கோங்க. சார் குட் ஈவினிங் சார். சார்
Yeah, Shivabalan sir, yeah, you are visible now, sir.
Hello.
Oh, good evening, Shiv.
Sir, good evening, sir. How are you, sir?
Sir, வைத்தியநாதன் சார் உங்களது ஃபேஸ் கொஞ்சம் கீழே தான் தெரியுது. அதை ட்ரீட் பண்ண முடியுமா சார் கொஞ்சம்? எஸ் சார், எஸ் சார், யா, எஸ் சார். Sir, we are waiting for Sendilvelu sir. He'll be joining in 2 minutes, sir. Once sir joins, we can connect, sir.
Hello. Hello.
Sir, he should join in 2 minutes. நம்ம அதுக்குள்ள ஸ்டார்ட் பண்ணிடலாம் sir. We will start the meeting so that he will join in the middle, sir.
Okay.
Vaidyanathan sir, is it okay, sir?
Yeah, that's fine.
Yeah, sir. So Chetan, you can open for delegates now. Chetan, you can confirm whether delegate is opened or not. Yeah.
Yes, sir. Just wait. Yes, sir. We are live now.
Okay. Thank you. Thank you, Chetan. Yeah. Shall we start, sir?
Yeah.
Thanks, sir.
Yeah.
Good evening, doctors. On behalf of Alchem Laboratories, India's 5th largest pharmaceutical company, I am Balaji. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on galaxy of experience on rosuvastatin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us to navigate through the entire meeting, we have with us today Senior Consultant Interventional Cardiologist Dr. P.R. Vaidyanathan sir, who will be our moderator for today's panel discussion. Welcome, sir.
Thank you.
Let me take this opportunity to give a short introduction about P.R. Vaidyanathan, sir. Dr. P.R. Vaidyanathan, sir, is a chairman and senior interventional cardiologist at JKNM Hospital, Coimbatore. Doctor has completed his MBBS in the year 1981 and MD in the year 1987, and he has completed DNB cardiology in the year 1994. And he has worked as a senior house officer at CMC Vellore, and he is in the year 1994 he has joined JKNM Hospital. Since then he is working in JKNM Hospital. Now currently doctor is a chairman as well as an operational director at JKNM Hospital for the Department of Cardiology. Doctor has got various rewards and awards. Couple of awards to mention is doctor has received Lifetime Achievement Award by IMA, Coimbatore Branch and Cardiology Society of India. Doctor also was a recipient of Distinguished Service Award at JKNM Hospital, Coimbatore in the year 2016. Doctor had got several publications in various national and international journals.
பாலாஜி இது எல்லாருமே தெரிஞ்சவங்க தான் பாலாஜி போறோம்.
Yeah, sir. Okay. Yeah.
All of us know சிவபாலன் எல்லாம் எனக்கு என்ன சிவா?
Yeah, sir. Yeah.
Yes, sir. Yes, sir.
Thanks, sir. So let me take this opportunity to introduce the other panelists. Firstly, I'd like to welcome Dr. Kannan, sir. Kannan, sir, is a senior consultant nephrologist who is currently practicing at Padma Kidney Center, Erode. Doctor is also a visiting consultant at Erode Kidney Center and Erode Trust Hospital and Sindhil Multispeciality Hospital, Erode. Doctor has completed his MBBS in the year 1986 and post-graduation in 1994 and DM nephrology in 1996. And he is practicing for almost 17 years now in Erode. So we welcome Kannan, sir. Welcome, sir.
Thank you, sir.
Let me take this opportunity to welcome the next panelist, Dr. Nambirajan, sir. Dr. Nambirajan, sir, is a senior consultant interventional cardiologist who is practicing at Coimbatore. Dr. Nambirajan, sir, he has completed his undergraduation in the year 1991 and he has completed his post-graduation in the year 1999. And he worked as a assistant professor of internal medicine in Stanley Medical College, and post that he has completed his super specialty DM cardiology in 2012 at Stanley Medical College, and he worked as a assistant professor in the Department of Cardiology in
Thank you.
Heelpak Medical College in the year 2016, and post that he has joined as a
Balaji, thank you.
yeah, sir.
Thank you.
Welcome, sir. Thank you.
Cardiology, GK இதில்ல எங்க government hospitals here.
Yeah, I'll just wherever doctor associated alone, I'll just give a details, sir. That's it.
Okay.
Yeah. Let me take this opportunity to welcome the next panelist, Dr. Sendil Velu, sir. Sendil Velu, sir, is a senior consultant diabetologist who is practicing at Maruti Medical Center Hospital, Erode. We welcome Sendil Velu, sir. And we have next panelist, Dr. Shivabalan, sir. Shivabalan, sir, is a senior consultant interventional cardiologist who is practicing at Coimbatore. Doctor has completed his DNB cardiology in the year 2011 and he is currently working at Hindustan Hospital, Coimbatore. Welcome, sir.
Thank you. Thank you.
With this short introduction, I will hand over the session to our chairperson, Dr. P.R. Vaidyanathan, sir. Sir, you can set the context for the webinar. Over to you, sir.
Good evening. Thank Alcom for this opportunity. We will make it very short so that on Saturday evening we can spend some time at home. So basically we know that coronary artery disease or vascular disease for that matter, one of the greatest risk factors is abnormal lipid. The discussion, from third year medicine onwards, we know that 1% reduction in cholesterol decreases the mortality or cardiovascular disease by 2%, decrease in LDL reduces it by so many percentage and all. And there has also been studies like whether the HDL increase in HDL has some role in reducing the heart disease, and triglyceride, whether they are important, whether there's a group of people in like diabetics, whether it is important, whether reduction really reduces the mortality, because available evidences in cardiology or many of the RCTs does not show much of an outcome benefits with fibrates which reduce triglyceride, etc. So with this is the basic concept on which we are supposed to have discuss some answers for some question. Reduction of ASCVD risk with statin. That is one of the best questions. Nambirajan, I think as a professor who teaches students, you should start. What is your outlook on this? What do you think we should do? Whether blanket statin for everybody above 40 is one of the principles, like HOPE-3 trial where rosuvastatin has shown some benefit, or do you select patients who are at high risk for statin? And what is the statin of your choice? How much do you give?
Yes, sir. Sure, sir. Right from the introduction of the statins, it has revolutionized the treatment of both the primary and the secondary prevention, sir. So a lot of trials regarding the primary prevention has proved beyond doubt that this statin has a reduction in cardiovascular mortality, and it has its own role in secondary prevention, mainly in reducing the further cardiac events, sir. So the risk stratification according to the ACC/AHA, they classify for all diabetic patients irrespective of age group. I'll just take the diabetic population, sir. So that 40 to 75 years, irrespective of the groups or cardiac risk score, you need to start them on moderate intensity statins, sir. Then they give further, if you want to increase, they give some risk scores to classify the diabetic severity depending upon the duration. Nowadays, they have taken the diabetes duration, sir, especially for type 2, more than 10 years, type 1 diabetes, more than 20 years, along with the end organ damage like retinopathy, nephropathy, along with the peripheral vascular disease and the EGFR less than 60 ml. These categories they prioritize as a high risk categories, and they advise high intensity statins for this group of patients, sir, especially atorvastatin 80 milligram and rosuvastatin 40 milligram. So with regard to high intensity statin, as we all know, despite the treatment with the high intensity statins, there are certain group of patients who have this recurrent cardiac events, despite your LDL being normal less than 70 or something like that. So this residual risk exists even the best of the treatment. The recent study in the Swedish population also, they have proved that under the heart protection study has clearly proven, despite simvastatin 40 milligram, there was 24% reduction in all-cause your cardiovascular events. But after 5 years, among the 24%, 18.6% they had recurrent events. So what does this mean? So there is some amount of residual risk, and the amount of LDL cholesterol reduction is not sufficient. So that is what being nowadays the focus of all the international societies. They focus the LDL should be lowered to the maximum best level. So the ESC and the American Endocrine Society, they all advise the LDL to be less than 55 milligram per deciliter, sir. In fact, our Lipid Association of India has done a tremendous work on this. Right from 2016, they have worked on this, and they have made a statement in 2016 itself. They have made the LDL to be reduced in high-risk patients, those who are with diabetes, with atherosclerotic 3 or more ASCVD risk factors, or recurrent cardiac events, or CKD stage 3 or 4. They insist upon high-intensity statins, sir. So the main idea is the role of statins is proven, but despite that, we do have a residual risk. This residual risk could be due to your dyslipidemic not being addressed properly to a level which is needed, because nowadays with the latest drugs, PCSK9 inhibitors, the improve trial with the evolocumab and estimate, all these drugs, all the ACC/AHA, they insist with the recurrent cardiac events, despite your statins and despite the LDL being less than 70, you need to reduce an add-on drug like estimate, sir. And if not, the 50% LDL reduction are not achieved, then you need to add a PCSK9 inhibitor, sir. So my contention is the lower the best. So we need to bring LDL to less than 50 in most of the our patients. We need to add on, if the statin with the highest dose statin, if it is not being corrected, we need to add on estimate. Even with the estimate, if it is not corrected, we need to add on PCSK9 inhibitors, sir. And one point also, despite the residual risk being accounted for not a proper control of LDL or dyslipidemia, there is an this out of context of this webinar, sir, there is an additional inflammatory risk also that can be discussed later, sir. So statins are the main ace.
We will
Thank you,
discuss
sir.
about the inflammatory risk and what is the role of different statins in preventing inflammation and other drugs in the later.
Yes,
Yes.
Jupiter trial has proven.
We will discuss it, Nambirajan. We will ask now our nephrology colleague.
Yes, yes,
CKD,
sir.
how we know that CKD is a risk factor for coronary artery disease. What is their take home on statin in CKD? Do they insist on a higher dose of statin? Do they have a special preference for one particular statin, like atorvastatin compared to rosuvastatin? Because there are some studies which say that the renal involvement may be more with. So what is their take? What do they do? Do they go for a higher dose of statin? Do they go by the LDL level and keep on adding other drugs? Does it influence their renal function in any way other than coronary? I think. Sir, Kannan, sir.
Sir, am I audible, sir? Am I audible,
you are
sir?
audible.
Yes, sir.
Okay, sir. Okay.
Yeah.
Yeah. Now, in our country, the incidence of CKD is very rapidly increasing following in the footsteps of diabetes and hypertension. And we also know that CKD is at one time considered to be a coronary disease equivalent, but now that view is no longer there, but still it is a very high risk for coronary vascular disease. There is an accelerated course of atherosclerosis with premature mortality. Most of CKD patients, they die of coronary heart disease rather than reaching the end stage renal disease, either requiring dialysis or transplant. And we don't have dedicated cardiovascular outcome studies as much as in cardiology, but we do have some studies like the SHARP study, and we have extrapolated the data from the group subgroup analysis of the cardiovascular outcomes. And now it has been conclusively proven that statins are very important both in the primary prevention as well as in secondary prevention. Our society guidelines state that all patients with the CKD, that is, and the GGFR is less than 60, the patient is above 50 years, or if the patient is less than 50 years with the patient having diabetes, hypertension, or a pre-existing atherosclerotic disease, or with the grouping of cardiovascular risk factors like smoking, obesity, sedentary life. So if the estimated risk is more than 7.5, definitely all these patients should be candidates for primary prophylaxis. So that means almost all the patients, CKD patients, are candidates for statin therapy. There is one view that you don't even have to do a baseline lipid profile for these patients. And the current consensus in our group is that maximum tolerated dose, because even though high intensity statins have shown that they reduce the mortality in CVD, many a time our patients may not be able to tolerate. So we have to use as much as possible. So that is as much as the patient tolerates. If the patient is not able to tolerate, then you may consider even ezetimibe as a first line therapy along with the statin. So among the two statins where we use atorvastatin and rosuvastatin, we prefer atorvastatin because it is non-renally, I mean, it is excreted through the liver. And some studies at least have shown that it reduces proteinuria and it maintains the GFR. So if we prefer atorvastatin, and if you want to use rosuvastatin, its dose has to be modified to GFR. If the GFR is more than 60, you can use up to 40 milligram. If the GFR is about 30 to 60, you have to use 20. If it is less than 30, you have to use 5 to 10 milligram of rosuvastatin. Whereas for atorvastatin, there is no dose modification as such, but you have to use it according to the how the patient tolerates. So whenever possible, it is a high risk for CVD. Most of our patients will die of cardiovascular disease rather than reaching ESRD. So we have to use in almost all the patients a statin as a first line therapy. And if the patient does not tolerate a statin, we can combine with ezetimibe even as a first line therapy. So that is both for primary as well as secondary prophylaxis. Thank you.
How much worry do you have about muscle symptoms and rhabdomyolysis in renal failure with high dose statin? Is it a hyped say a concern, or do you really see, or are you really bothered to
especially with the patient? And rosuvastatin is a very potent statin. If you use more than 40 milligram, definitely the risk is high, according to some studies. But in practice, if you are asking, we usually use 20 to 40 milligram of atorvastatin with or without ezetimibe. We don't see much of rhabdomyolysis. And rhabdomyolysis, it need not be screened. Only if the patient develops some symptom pertain to muscles, you can screen for that. So there is, you should not be worried about rhabdomyolysis or even myalgia. The patient tolerates, you can continue.
Thank you, sir. Shivabalan, are you there? Namirajan, Dr. Kannan has raised one important point.
Yes, sir.
Which I think was in Hope study also, that ideally you don't even bother about the lipid level in all these high-risk patients, and you should start them on statin, whatever be their level of cholesterol, because their risk of CAD vascular disease is much higher. What do you think about that practice?
Yes, in CKD, you're saying this. CKD 2000, all the ESC guidelines, they clearly say despite the cholesterol level, when the GFR more than age 50 years and the eGFR is 60 ml per minute, and there is albuminuria, independent of the cholesterol level, you should start them on moderate intensity statins, sir. This is the ESC guideline. And as Sir said, the SHARP trial has actually had a beneficial primary endpoint on MI cardiovascular death by 17%, sir, and 32% reduction of LDL clearance was there, sir, in SHARP trial. And there are some other trials, especially rosuvastatin, Aurora trial, CKD and hemodialysis. And in that also, but most of the CKD patients, the vascular disease will be actually very much severe. So the reversal in case of CKD, and especially they have said in aortic stenosis also, this statins doesn't work because already the patient is on the severe end-stage diseases and the vascular endothelioma, the complications would be very high. So you cannot expect the benefit as much as in other cases like coronary artery disease or something like that. But we can definitely continue. It has its own benefit when started early, sir. Even on hemodialysis, we can give rosuvastatin, sir.
Okay, so see, the question is, do we really have to check? Suppose you have too many risk factors and your cholesterol, you are a hypertensive, you are a smoker, you are a diabetic. Your cholesterol level somehow is within normal limit, or your LDL is within the range which we usually say it's not high risk. Will you start them on statin or not? Is the question which I think we will have to answer. Do we go by a lipid level to start statin in a high risk? Do we need a higher level of lipid for starting statin? Kannan sir, you have some opinion?
Yes, sir. Rather than only on depending upon the cholesterol reducing effect of the statin, they also have other pleiotropic effects. they improve the endothelial function, they are anti-thrombotic, they stabilize the plaque. So many other pleiotropic effects have been described, and the same pleiotropic effects are what purported to reduce the proteinuria and maintain GFR, and they also, and to some studies, suggest that they can even reduce blood pressure. So even if the cholesterol level is in the stipulated level, stipulated range, we have to continue statin for not only for their cholesterol reducing effects, also for their pleiotropic effects. That's my contention.
Nambirajan.
Sir, your question is very clear, sir. You're asking whether the patient does not have, even if the LDL is low, if the patient has some risk factors like premature CAD, or family history of CAD, all the risk factors, definitely we need to start them on statins, sir. We need to start them on statins because the metabolic syndrome or an increased obesity in all these patients, we need because these are all the patients who go in for further complications. So the statins, but I can't exactly give the guidelines.
No, I think everything is clear that you don't go by statin, lipid level alone. That is why you calculate the risk score of a person. Most of the time, score calculate not by the cholesterol alone. So many factors are taken into consideration. And the risk score according to the guideline, if it is more than 5% or more than 7.5% in ACC/AHA, you are supposed to start them on at least moderate dose of statin. And as the risk score keeps going up, you have to increase the dose of statin depending upon the situation. How many of you really think that the CRP on the influence of rosuvastatin in CRP really influence your decision to start rosuvastatin compared to atorvastatin? Because the Jupiter trial showed that CRP decrease is much better, and we cardiologists are always worried about acute coronary syndrome and inflammation as a cause for acute coronary syndrome. And how many of you think that that influences your decision, or we use interchangeably both the drugs features?
No, sir, definitely rosuvastatin scores over other statins because of this Jupiter trial, sir. Because as we all know, this the recent CANTOS trial has highly emphasized the fact of inflammation. Inflammatory risk is the one of the important it increases the atherosclerotic vascular disease. So we need to address that. So definitely we need to consider rosuvastatin in case of if you consider. And in fact, sir, we don't really measure the CRP in all the patients. So we should make it a practice to measure CRP in all the patients who are prone to coronary artery disease. Then we should start rosuvastatin as the first drug of choice, sir. Especially if the LDL levels are more than 70, we need to start them on high intensity statin if there is an atherosclerotic cardiovascular disease.
And then, sir, does it influence your decision making?
The thing is, in chronic kidney disease itself is a very inflammatory state. So even if you do all the patients without a cardiovascular disease or atherosclerosis also, you will get a high CRP level. So that really doesn't give a clue. So as I said, there are other reasons for choosing atorvastatin over rosuvastatin in our patients. So we still go by that. If the patient tolerates rosuvastatin, sometimes in a moderate intensity, we do give.
Nambirajan sir, imagine we discuss so much about inflammation as responsible for acute coronary syndrome, inflammation for progression of atherosclerosis. But most of the data on acute coronary syndrome and secondary prevention are on atorvastatin and not rosuvastatin.
Yes, sir.
At least a few persons who think that basically rosuvastatin is not the drug for secondary prevention and it is a drug for primary prevention.
No, sir. Actually, the galaxy of studies with the rosuvastatin, for example, the Jupiter and especially the Meteor study, which compared the coronary, the carotid internal media thickness, and your corona study with rosuvastatin with heart failure. In that study also, the CRP was very much lowered with the rosuvastatin, sir. And especially your asteroid, that is the intravascular ultrasound derived coronary atheroma burden. Rosuvastatin proved beyond doubt that it regresses the atheroma volume, and there is plaque regression, and there is definitely IVUS evidence of decreased atheroma volume, sir. So we cannot ignore these trials. Definitely it scores over atorvastatin in beyond, apart from reducing the LDL levels, sir, because it's a potent statin than atorvastatin, sir. So we need to consider rosuvastatin.
Senthil sir, what is your take on atorvastatin with versus rosuvastatin in acute coronary syndrome, and inflammatory markers as responsible for, as useful marker, and rosuvastatin reduces the inflammation much more than atorvastatin. Dr. Senthil? I think he's not there. Okay, the next question which is asked is, rosuvastatin, what is a moderate intensity statin, high intensity statin, low intensity statin? Like 10 milligram of atorva, 20 milligram of, 5 milligram of rosuvas are considered to be low intensity statin, etc. How many of you go by that? And how many of you really start something like 5 milligram of rosuvastatin? There is some data on Asian population which said that 5 milligram of statin may be useful in an Asian population. But how many of us do it? Who wants to answer? Sir, only 2 of you are there.
Sir, actually, the statins are very much underused, sir. We are not writing the right dose in any of our patients. We are scared to write, and we are, because of side effects like muscle symptoms and other things. In a recent study, in a meta-analysis done in India, sir, they were the high-risk patients were found to be only 5% of the high-risk patients are being given the right dose. So to say, and we also de-escalate, sir, in our coronary patients. After 3 months, we de-escalate them from atorvastatin 80 or rosuvastatin 40 to reduce dose. So in accordance with the recent guidelines, if you want to achieve a LDL goal of less than 50, according to the latest guidelines, we need to continue the high intensity statins, sir. There is no doubt that we should consider either atorvastatin 80 milligram or rosuvastatin 40 milligram until a year, and then only we can take a call. If there are no, the patient is not tolerant, you can go in for a non-statin therapy like estimate, PCSK9 inhibitors. I don't have an experience, sir. Maybe you might have used. It's too costly affair in our country. So, your say, sir.
PCSK9, we have not many patients. I have around 5 to 10 patients on PCSK9.
Okay,
There are people whose level of cholesterol has been more than 190, in spite of an adequate dose of statin plus ezetimibe, and people who have recurrence of MI and all. The only problem has been that cost is one factor, but there is definite reduction in LDL level with PCSK9 inhibitor. Do nephrologists use PCSK9 inhibitor?
We are even scared to use high dose, high intensity statins, and we don't have any experience. I don't have, sir.
Senthil sir, do you have experience on PCSK9?
No, sir. Good evening, sir. Sorry for the delay. I got held up. Yes, sir. I don't use that so far.
We were discussing
Yes,
high intensity statin. Sir, your basic specialty is cardiology or?
Diabetes and internal medicine.
Okay, I was waiting for you. As a diabetologist, how commonly do you use a high intensity statin? because most of the diabetologists
Yeah.
reduce the drug dosage once we
Yes, sir.
cardiologists start a higher dosage. When it goes to the diabetology, they come back with half the dose of what has been given. What is your take on high intensity
Yes, sir.
statin?
As you said, yes.
Diabetics with this,
Yes, sir.
I mean,
Whenever it is in the acute coronary syndrome or stroke followed in acute event, the neurologist and the cardiologist start high intensity statin. Followed by after 6 months, when they want to reduce, they come to a diabetologist perspective. We maintain with that, and according to the lipid level and the comorbid condition, normally we try to reduce because of the stabilization of the chronic disease. Because we do see most of the patients with uncontrolled diabetes and comorbid conditions, where without any acute event, we try to present the 10 mg and the maximum 20 mg. When they go to rosuvastatin, especially. Otherwise, maximum 6 months to 1 year, we try to reduce and maintain the dose to have the plaque stabilization and the long-term benefit in the diabetic patients. High or
sir, basically, data most of the time shows that you don't have to reduce the dose of the drug because your lipid level is something like 50.
yes,
Because
yes.
the PCSK9, even 28 milligram of LDLD is supposed to be useful or is not harmful at all.
Yes,
And so, cardiologists as such don't try to reduce the dose of statin minimum for 1 year. After
Yes,
that,
sir.
probably the patient complains of something or they ask you. We don't go by the lipid level to reduce a statin unless it's a gross reduction, like a total cholesterol comes down to 70 and all, we may reduce. Otherwise, I don't think. Nambirajan, sir,
Yes.
you have any?
Sir, actually, yes, we should continue for a year, sir, as you said. And we can, after 6 to 8 weeks, we need to check the levels, sir, whether it is our aim is to reduce the 50% of the LDL cholesterol, sir, 50% of the initial level. So when it is not, when it is coming, then we should maintain the same dose, sir. With moderate intensity statin, 30% of reduction of LDL should be okay, and we should continue the same dose, sir. After 1 year only, we can take a call, sir.
Kannan, sir, you want to add something?
Same thing, sir. Actually, the best person to decide about this will be a cardiologist, especially if the patient has been recently treated for acute coronary syndrome. Definitely, he should make the decision. And we usually follow his advice. Only if the patient has some intolerance or if the patient has some side effect, we reduce the dose. Otherwise, as a prophylactic dose, we use only moderate intensity. If the patient develops some acute coronary syndrome or other MI, definitely we will go for whatever the cardiologist says.
As a diabetologist, sir, do you give statin for everybody above 40 years or everyone above 5 years of diabetes or 10 years of diabetes? What is your take, sir? Sendil, sir.
Yes, sir. Usually, according to the A1C and the definition of diabetes, we plan that is the reduce the lipid level. And with more than 2 risk factors, we generally discuss with our patients nowadays, because once you add drugs, they have their own Googling and talk to the chemist and want to reduce. So we try to tell them that rosuvastatin at least 5 mg or 10 mg is beneficial in long-term separation of the plaque and reduce the complications better, like in the form of preventing attack or postponing the acute event. So we generally tell them after 5 days, even the cholesterol will be around 160 or 180, but we are more worried about the small density LDL cholesterol, oxidized cholesterol. So we try to tell them, even though the lipid levels are slightly higher, any diabetic, they need a statin to have long-term benefit. Aspirin, this on the day we discuss and then add, but statin we try to add nowadays.
What is your take on fenofibrate in a diabetic?
Yes, when the dyslipidemia is mainly triglycerides more than 150 with other comorbid conditions, we try to add fenofibrate for 6 months. And when we repeat triglycerides, if it is the same level, we try to continue. When the lipid triglycerides goes above 250, now we have saroglitazar, which we add dual gamma inhibitor. So that takes care of both.
has not taken up with cardiologists. We don't routinely write saraglutazone.
Yes, sir. Now we have a lot of evidence, including fatty liver, sir. So for saraglutazone, we have both good control of diabetes like the metal with the good reduction of triglycerides, especially when it's above 500. We do see very good reduction of less than 150 within 3 months.
Sir, level above 500, your indication is totally different. It is not coronary artery disease. Level above 500, you are worried about pancreatitis and you want a rapid reduction. The question, somebody diabetic on statin, diabetes is not well under control. Triglyceride level is something like 200, 250. Should you be putting them on a fenofibrate? Nambirajan sir, did you hear me?
Definitely, we are putting in the aim to reduce one.
Somebody with an uncontrolled, not well controlled diabetes on statin, triglyceride is around 200, 250. Do you start them routinely on fenofibrate or tell them to get the diabetes under control? Unmute.
Till he gets unmuted, sir. Definitely, we do concept.
Sir, definitely, Senthil sir, please.
Yes, sir. And we try to control diabetes and exercise them as soon as we try to control this kind of rate for 6 months.
No, the problem with cardiologists, sir, we don't have much evidence on coronary artery disease and fenofibrate. Nambirajan.
Sir, triglycerides, when it is more than 500, we need to add fenofibrate. Sir, this was clearly shown in field trial. And normally the statins also take care of your reduction of triglycerides to an extent, sir. So we need not add upon a fenofibrate. And it has not been shown in many trials that it is not associated with any decrease in cardiovascular events. There are no beneficial effect of addition of fenofibrate, sir. So it is not advocated routinely, especially in hypertriglyceridemia, pancreatitis only fenofibrate role is there, sir.
That is the difference between a diabetologist take and the cardiologist take. I'm sure nephrologists are not interested in fenofibrate because they are worried about the creatinine level.
Yes, sir. Fenofibrate, especially in combination with statin, increases the risk of rhabdomyolysis, and we don't routinely use. And fenofibrate, the dose also has to be reduced to GFR. Sir. So we don't use, only the triglyceride levels are above 500 and only for prevention of acute pancreatitis, not for cardiovascular indications. So definitely, we don't use at all, sir, to be frank.
It's a big no for them. Cardiologists have a take and the diabetologists have a different opinion on that. The concept is that once you start at fenofibrate, probably the LDL particle will become larger, so less atherosclerotic, and the HDL also will become better, so that the protective effect of HDL will be better and the LDL atherogenicity will be lesser, but they have not translated into real clinical practice. I think the only last question, other things have been answered. Secondary prevention, evidence and experience, and versus primary prevention. Do you really differentiate which strategy primary prevention versus secondary prevention? I think Nambirajan sir has already explained this once, but once again, we will.
Sir, yes, sir. The secondary prevention trials, they have clearly showed that in very high risk and moderate high risk patients, the statins have proved in a better way, sir. Especially right from the starting of especially in high dose statins in prove it trial and the TNT trials, atorvastatin 80 milligram, there were 22% relative risk reduction, sir. And all statins pulled together in a meta-analysis, they have proven that around 16% of cardiovascular death reduction is there with the statins. So with this, all this robust evidence with the secondary prevention, we need to continue, sir. But as I already said, there is some amount of residual risk despite the high dose statins. And as the Lipid Association of India and the American College of Endocrinology and the recent guidelines, we need to target the LDL to a much lower level, sir. We need to consider high intensity statins if you want to achieve the right amount of benefit in secondary prevention.
Now the question is, do you choose atorvastatin over rosuvastatin in secondary prevention and rosuvastatin over atorvastatin in primary prevention, or routinely use whichever drug comes to your pen on that day, and you don't think there is it's a generic effect and not a specific effect of one drug over the other?
As we have already discussed, some amount of inflammatory risk is there with your coronary artery disease, and a lot of studies like CANTOS using canapigumab and other drugs, they have proved that there is an inflammatory risk in atherosclerotic process. So this CANTOS trial also proved that there was enough evidence and enough benefit with this anti-inflammatory drugs. So much studies are being awaited, sir. So in that scenario, rosuvastatin definitely scores over atorvastatin, sir, because in Jupiter trial and other trials, Asteroid and it has Meteor trial. So all these trials, it has proved beyond doubt it scores over because it reduces the hsCRP, which is a marker of inflammation. So there is no doubt rosuvastatin should be the drug of choice in all high-risk patients, sir. I don't think there is any specific contraindication for rosuvastatin, sir.
Diabetologist, you have some preference of atorvastatin over rosuvastatin. Do they differ in their hemoglobin A1C worsening? Do you really choose like that, or give whatever drug is?
Yes, sir. There are some studies initially implicated of worsening of statin, but generally statin we try to continue. We don't attach more concentration on HbA1c variation with the continuing statin. So definitely we have to put statin, and that is beyond our range.
Sir, your audio has some problem.
Hello, sir. Is it audible?
Yeah.
Is it audible, sir?
Yeah.
Yes, sir. So definitely we are more focusing on using of statin to majority of diabetic patients. Atorvastatin or rosuvastatin, we don't now see at the HbA1c variation. So I don't have my experience in concentrating on the different treatment group. Initially, when they tolerate well, older patients used to put only atorvastatin 10, 20. Now instead, we are more favoring towards rosuvastatin 5 and 10 for most of the diabetic patients for plaque stabilization and prevention of both primary as well as secondary.
I think we have answered all the 4 questions given to me for discussion. Any other point anybody wants to discuss?
Kannan, what about the renal EGFR and rosuvastatin decision? How do we go with that? Because
we already answered, but you were not there, so we asked Kannan.
And the creatinine level and the choice of statin.
Atorvastatin is hepatically excreted. There is no dosage modification. But for rosuvastatin, there is dosage modification. Stage 1 and 2, usual, high intensity if you want to give 40 milligram. Stage 3, 30 milligram. Stage 4 and 5, 5 to 10 milligrams.
Yeah.
Balaji, anything you want to?
Sir, there is one query which has come. So usage of omega-3 fatty acid. There is only one query which has come in there.
Shiva, do you use omega-3 fatty acid? Omega-3 fatty acid, do you use in your practice?
Yes, sir. Selectively, few patients I have used, sir, especially people who have high homocysteine, serum homocysteine, and young people, especially who are more prone to develop thrombus, intravascular thrombus. So selectively, I prefer omega-3 fatty acid, sir.
We don't routinely use. The group
Yes.
of people in whom we use will be very limited.
I've used in cognitive dysfunction improvement, and when they have high triglycerides level, it can be
it is known to reduce.
Yeah, so for that, young individuals who are having high below 40, I generally prefer fatty acid, and homocysteine level is high with folic acid.
Actually, the recent trials reduce it. In that trial, they have used this omega-3 fatty acid fish oil, 2 grams per day, sir. And it was found that there were actually the LDL cholesterol was around 100 milligram, and triglycerides were around 500, sir, 140 to 500 in that study. And it has also there were in diabetic patients they have used this drug, and it was proven to be they had mortality benefit, and there were 25% reduction in primary endpoints, sir.
How big is that trial? How many patients?
Around 8,179 patients, sir, with the established cardiovascular disease and diabetes. They have followed.
Statin and.
Pardon, sir?
Baseline statin and standard of care.
Baseline statin, I think they haven't mentioned, sir. Mainly for hypertriglyceridemia they have given. They have included hypertriglyceridemia as one of the.
That is the problem. Most of the trials on statin, when we added fenofibrate or nicotinic acid for that matter, triglyceride reduction did not show much benefit. So whether this is a trial which is on statin, people on statin or naive of statin is something which will make a difference in our take on that. If no other question, shall we conclude? Yeah.
Yes, sir. Yes, sir. I think all the queries had been completely covered now. Yeah, sir. It's my pleasure to propose a vote of thanks today evening. Firstly, I'd like to take this opportunity to thank Dr. P.R. Vaidyanathan, sir, for accepting our invitation and moderating the panel discussion today. Thank you, sir. And I'd like to also thank all the panelists, Dr. Kannan, sir, Sendilvelu, sir, Nambirajan, sir, and Shivabalan, sir, for sharing your views on experience on complete rosuvastatin in your clinical practice. We'd like to also thank all the doctors who joined us for panel discussion today. And I'm sure all the doctors will be appreciating the views which has been presented by the panelists, which has been presented today. So at this juncture, we like to salute all the doctors and paramedicals who have contributed immensely for keeping us all safe and healthy in these challenging times. Dr. B at Alkem Laboratories will continue to serve doctors and patients by making our products available, especially our chronic brands, Jupiros, Volcom, and Gluvilda. Thank you, sir. Thanks for the opportunity given. Have a nice evening, sir.
Thank you, sir.
Thank you, sir. Thank you, Chairperson, and all the.
Thank you. Thank you, sir.
Thank you, sir. Thank you.